Hello, everyone. So welcome to Lecture 2 of U.S. Health Systems. Today, we're going to be talking about the medical system from 1920 to about the 1970s. Of course, we ended last time with around 1910, and there's a block of time we're missing in there that we will go back to as your reading catches up. And of course, that's and where we'll be contrasting the flu epidemic from in 1970 to COVID now. So I didn't want to get too bogged down with that yet because we're really going to go over it, and it doesn't have a lot to do with medical services or as much as it just has to do with how we deal with plagues and that kind of thing. So we will be going back over all of that. You will find that in these first three lectures, I'm kind of rushing through history, and we will we'll come back around to some, especially more modern medical services in more depth as we continue on, especially with the manual book. So I am going to shrink me and we're gonna dig into it. So at this time, about 1920, after the Flexner report, growth of professional sovereignty and cultural authority. So there was, in the United States in general, we started to see more urbanization as well as in Canada. There tended to be more movement in the medical profession. People were starting to trust doctors more because they were being trained in very specifically. So we are no longer seeing doctors only getting, a couple months of training. They're actually going through medical school now. So the trust is starting to come back. And there's less resilient reliance on your family members to treat the sick, and there more reliance on doctors. Less distance to medical care because, of course, when we start to urbanize, we see, you have doctors right there for you. But of course, still at this time, we had quite a bit of rural communities, and those really didn't change much. Similar to now, not a lot of doctors in our rural communities. We know that in Merced, it's our medical system is totally overburdened, especially now. So just to contrast this, in 1840, like we were talking about before, physicians were only able to see 5 to 7 patients per day. But now with industrialization, better transportation, in the 1930s, now doctors are seeing 18 to 22 patients per day. So science and technology is also advancing at this time. So we are starting to see innovations both in the day-to-day work as well as in clinical practice. But there's only so much each doctor can do. If they want to do more, they have to, it requires more skills. So, and the cultural authority by populations, physicians now need experts. So this is where we start to see physicians, instead of just having to know everything, now we're seeing some specialization. And institutionalization. So we're starting to see the bigger clinics coming in, larger hospitals. Hospitals are no longer just a place for the poor people to go. there's also so that because of all these new technologies, they're very expensive. So this means has to be more pooling of resources, and this is really where hospitals started to really take off now. They're able to work with many different doctors and have more money coming in, and they become dependent on physicians' referrals to them for all these new technologies, x-rays, and that kind of thing. And because of this now, before, remember, physicians really didn't have that much to do with the hospitals. They were just not as involved, but now they're referring patients over to hospitals. So they're becoming much more influential on how hospitals will be run. However, just like we're seeing now with COVID, when you start to bring a lot of sick people into one area, you start to see more infections and more deaths and that kind of thing. So patient dependency, as medical treatments become more complex, patients are now expecting to adhere to whatever the doctors are saying, without really much understanding on what they're doing. So this is a child in a oxygen chamber. He may have asthma, he may have something like that, but parents don't know. And I think this is still an issue today, where a lot of people are just depend on what their doctor tells them, and there's not a lot of explanation going on. Now we're also starting to see insurance come into the picture, and but at this point, insurance is more requires more of a physician's okay before they'll pay, which is very interesting. We don't see that much anymore. As medicine requires more resources in hospitals, physicians need to work together at this time, starting for common interests. And this is when the AMA really starts to take off. So remember, the American Medical Association is it started in the 1800s, but now it's beginning to really grow in strength and power within our medical system. Doctors really don't want to be under a hospital or under the government control at this time. So that's why they relied on the AMA. Licensing. So now after the Flexner report, now in order to be a doctor, you have to have a medical school certificate of recognition and passing exams. So physicians also have a monopoly on the number of people going in and into schools. And they still have that. They still control the number. The AMA controls the number of licenses given, and thereby controls how many people are let into medical schools. And this also causes the salaries to increase. Remember before in the 1800s, it was hard to be a doctor, and earlier, like, you couldn't see that many patients. It was hard to be paid. So this was a big deal to keep good doctors. And so now that the doctors have control over how many licenses and are given in the United States, as well as what schools can give out or can accept, now they're seeing their salaries rise. So, and of course, we talked about some educational reform earlier. In 1871, Harvard Medical School became our first medical school affiliate from medical school affiliated with the university. So their academic year was 9 months. The education was 3 years. And this is kind of what all of the schools after the Flexner report had to start doing. And it emphasized on laboratory and clinical instruction. Then in 1893, John Hopkins started offering medical training for graduate degrees. And John Hopkins is still among the premier medical schools. And it is the one that the school that was flagged by Flexner for other schools to follow. So, of course, at this time is when public health really started to take off. We had, of course, the pandemic with the influenza in 1917. We also had, at this time, TB was a big issue, and many other infectious diseases. So they about the turn of the century and beyond, public health really became a force, especially in New York and a lot of the eastern states. So the focus of public health has generally been sanitation, epidemics, and regulation of food and water. However, once immunizations and that kind of thing started to come, we started to get polio and vaccines and those, then public health took a large role in child immunizations and care for mothers and infants, as well as health screening. But this actually made physicians a little nervous when the public health started to get into immunization and maternal and child health. But so that is why we have the system we have today, where we have WIC and public health. Usually, so you have some public health clinics. It really depends on the county, each county, how that is done, and how much government control each public health department has. So biomedical advances in medical care and public health. Hang on just a second. Oh, my water's. So 1906, the Federal Meat Inspection Act came in, and there's many horrible stories about how our meat was handled prior to this time. John Hopkins founded the first medical school with a grant from the Rockefeller Foundation. Fleming's accidental, so this is in 1928, we discovered penicillin, groundbreaking. This turned around many infectious diseases, and or not so much diseases, but infections and that kind of thing. And then, of course, the public health was originally focused on food and water. And we covered that. Okay, so just to kind of really think about those big advances that have gotten to us to where we are. So 1941, penicillin, 1949, cortisone injections. In 1950, epidemiological approaches to TB and lung cancer. 1950, chlorpromazine and psychiatry really took off, and I'm not pronouncing that correctly. 1955, we had our first open heart surgery, and that's what this is a picture of. Successful open heart surgery. In 1961, we started doing hip replacements, and in 1963, transplants. In 1964, we've discovered ways to prevent strokes. 1971, our first childhood cancer treatments. In 1978, the test tube baby was born. And 1984, Helicobacter and peptic ulcers were controlled. But what did we get wrong? So many of you, well, all of you have probably already heard of the Tuskegee study of untreated syphilis in the Negro male. So this was a horrible, horrible research program that was done. Oh my gosh, I think it was done through NIH, I'm not sure. I have to look back at it. So it was originally only supposed to be a short-term research study, but it lasted from 1932 to 1972, so over 40 years. It involved 600 Black men. 399 of them had syphilis, and 201 did not have syphilis. The men never were, there was no informed consent. They didn't really know what was going on. They were told they were being treated for bad blood, and really they weren't being treated for anything. When this started in 1932, it did start, I mean, it was a syphilis study to find out how to cure syphilis in African Americans, but by 1945, penicillin had become an accepted treatment for syphilis. But none of these men were ever treated, nor were they told there was a treatment. And basically they wanted to see how syphilis would grow in the population, or the long-term effects of syphilis, which we really already knew. So it was very, not really sure why they would continue on with this. Many of you may have heard of Henrietta Lacks. There's an amazing movie, a docudrama. I think it came out 4 years ago or so. I'll put the link in. It's, I think, an HBO. I'll check and see if I can find it somewhere. The book is also very good. But Henrietta Lacks had ovarian cancer, I believe. I'm trying to remember. I don't know if I put it in here. I don't think I did. I believe it was ovarian cancer. Anyway, she went to Johns Hopkins for treatment. And while she was going there, they tried many different things. They did give her early radiation therapy and many other therapies to try to control her cancer. It was horrific. She would come home with burns and all kinds of just feeling poorly, and she still had to work and support her family. But I'm not sure. It's not that they were necessarily testing on her. They were trying to stop her cancer. However, in the process of this, when they were drawing blood and taking cells and uterine cells, they found that her cells actually survived for a long period of time, and they could keep them outside the body and they would survive. This was unheard of at this time. They had been trying to find cells that they could do this on, so they didn't have to keep testing on people. And that's all well and good. But the problem with this was they never told her that about her cells, and they never told her or asked her if they could take her cells. They just did. The companies, many pharmaceutical companies and research made millions off of her cells because they were used in many different experiments. They helped create the antiviral drugs for AIDS. They used them recently to try to work on the COVID virus. Her cells didn't work well with that. They found fetal cells that were better to do research on for the COVID virus. But the problem was that her family has never received any of the millions and millions of dollars that they have made with her cells. And at this time, Johns Hopkins really didn't make anything either. They created the cells and they would loan them out, give them out, but then other facilities would just repeat that. So her cells are all over the world. They're used everywhere. And never has she gotten credit for that, nor has her family. I think now Johns Hopkins is trying to make it better, but it's in the process, her family has been destroyed when they could have used some money for school or what have you. So these two studies have really led to what we now have for why we have to go through all of the hoops and everything that, as researchers we complain about, but we have to remember that these are things that have happened to people in the past. And these are only two examples. There's many more. These are both interesting, I thought. And then they do show the racism that's in our, still within our system, as well as sexism. They probably wouldn't have done this if she wasn't a woman as well. So causes of death start to change in the 20th century. So we move from influenza and those kind of the epidemic type of deaths to we start to see more cardiovascular deaths, cancer rate. It becomes a big deal. Let's see, what is this one? Oh, cardiovascular. But we do see, we have for cardiovascular, I think it's interesting also. So this is like heart attacks and that. So it climbs and climbs and climbs and climbs. And we kind of peaked in the 1970s, it looks like. And we've really, through diet, exercise, and to be perfectly honest, the different drugs that have come out, the statins, to reducing cardiovascular disease to below 1900 levels. But it is still our leading cause of death, right? So it's by no means cured. And then of course we have cancer here, and it climbs, and then it just starts to level off in 1970, also due to medical advancements. But you see here, where are we? What is this one? It's hard to tell. Oh, so we have influenza. Of course, we have a peak here. And that's about 1917. Then it drops way off. But if this were to go out further, we'd see another huge peak with COVID, unfortunately. So life expectancy, it continues to climb like we saw before. So the rise of the modern healthcare system. So from in 1900s, it was early 1900s, it was really fee for service. So you went to the doctor, you paid the doctor. The problems are workers out of work can't pay, right? Or if you don't make that much money, you can't pay. Medical care was becoming more and more expensive because of all these new technologies and expertise that they had. And then, of course, economic downturns. We had the crash of the stock market in the late in 29. So that then led to the Great Depression, and nobody could go to the doctor. And we always have some ups and downs within our economy. So this resulted in employers for the first time offering workers' comp and health care. And this was done primarily through unions, but also through employers on their own. So the focus at this time early on was on paying widows or getting people back to work. So if someone was killed on the job, which happened quite a bit, OSHA was, I don't even think in existence yet. They would have a widow's pension. And because again, women at this time really didn't have a lot of options, and they definitely did not make as much money as men, but they still had to take care for their families. Or if men got sick or hurt, they would help get them back to work. So private health insurance offered is basically an income protection during a sickness or disability. And it really benefited the hospitals and physicians because now they didn't have to worry about being paid. They knew that they were going to get paid. So I'm just going to briefly go over this. So we already went over in 1912, started the debate, was our first debate about universal health insurance. So by 1917, the whole idea went out the window because at this time, actually the first country to have universal health insurance after I think it was even before World War I. Actually, yes, it was way before World War I, was Germany. And, World War I starts and all of a sudden anything German gets thrown out the window. And there's no way we're going to follow Germany or the Kaiser. And so in 1933, Blue Cross was introduced, and we're going to go into this in more detail. In 1935, Social Security was then introduced, but this did not have a health care provision. This was basically just a retirement supplement for older Americans. And this is because the AMA did not want healthcare in it, and we'll talk about that. In 1939, Blue Shield was introduced. 1946, Truman introduced another universal healthcare bill, and the AMA killed the bill. They did not want socialized medicine. In 1965, Medicare and Medicaid were created. In 1974, Nixon actually introduced universal health care again, but it was actually killed by Edward Kennedy. And we'll talk about that. In 1982, Medicare was introduced DRGs, and these are how costs are figured within for Medicare. In 1993, of course, Clinton introduced universal health care bill. In 1994, the Harold and Louise ads killed the Clinton bill, and we'll talk about that as well. In 1994, Oregon introduced the Oregon Health Plan. 2003, Medicare Part D. 2006, Massachusetts started their healthcare plan. And then 2010, we finally passed a healthcare plan, but not universal healthcare. So the national insurance debate, 1883, in Germany, they introduced basically a sickness insurance, and it grew throughout Europe and it was everywhere by 1912. And this wasn't what it is today, but it was definitely, if you got sick, you were able to go to a doctor and it would be paid. In America, the American Association of Labor introduced it in 1912. It was part of Theodore Roosevelt's platform when he was running for president. So he had a very progressive platform. At this point, the AMA actually approved of some sort of universal health care. Remember, everything's just getting started at this time. But then World War I broke out, and that just killed everything. So no one was going to go for anything that was in Germany at that time. So then the 1930s, Social Security was introduced. And this is because at this point, we're in the middle of the Depression. Old people were starving in the streets, and after working their whole lives. So they introduced Social Security, and this gave money to the states to provide assistance to both the elderly, the unemployed, aid to families with dependent children, maternal and child welfare, public health services, and the blind. Remember, we're in the middle of, it's kind of like now where the federal government's pushing money out to the states, hoping that just to steady the boat a little bit. So this helped pay. This was paid by the current workers to retirees, and it still is. So that's why we pay into Social Security. All of us pay into Social Security, and then that money actually pays out to the seniors who are retired now. So the first monthly payment was January 31st, 1940, and it went out to Ida Mae Fuller. She was paid a total of $24.75. She lived to be 100 years old and collected a total of $22,882.92. And again, this did not include healthcare. So private insurance was introduced, first in Minnesota, and Texas wasn't far behind. It was basically nonprofit covered hospital charges. It did not include physicians because the AMA did not want it to include physicians. And it then covered 57% of the population by 1957. So then Blue Shield started in California in 1939 to pay, and basically this started to pay physicians' fees. Physician-dominated boards set the reimbursement levels. So that's why the reimbursement levels are higher for the on insurances. The AMA wanted medical records, however, to remain with the physicians, and so they were. So just a little timeline. kind of looking forward. So, of course, we talked about biomedical advances in Medicare and the beginnings of public health. Prepaid group practices started right around 1910. Origins of Blue Cross, and this was Texas and California, and Minnesota. And the growth of private insurance by Blue Shield in 1930s. Whoops. So, and then increase of employer. So now we're looking at increased employer-based health insurance. We're going to be talking about that. Okay, so the increase of health insurance in the United States. So it started off in the 1940s, and it just started to grow. So commercial insurance are for-profits. The Blues have been considered nonprofit, so Blue Cross Blue Shield, Anthem. I don't know if they're still nonprofit. I think they're for-profit now. But they kind of started to level out, but they're still climbing. But the for-profit health insurance companies just spiked. So why? Let's see. Okay, so I'm going to stop sharing. I don't know if I have to do that. I think I can just click this because it's just and let me hold on just a second. Sorry, I'm going to. I think you should be able to hear this. Okay. All right, that's not the one I want. Sorry, little music. Here we go.
From NPR News, this is All Things Considered. I'm Melissa Block in California. And I'm Michelle Norris in Washington. First up this hour, we have a story that begins with some old-time potions, promised cures for just about any ailment. And it ends with our modern-day healthcare system. It is a story of how we wound up with a system where employers pay for health insurance. So how did we get here? After all, employers don't pay for our groceries or our gas. NPR's Planet Money has been exploring this question, and as Adam Davidson and Alex Bloomberg discovered, there was never any central logic at work, just a bunch of accidents that brought us to where we are today.
To learn about how we got our modern healthcare system, you do have to study history, but you don't have to study too much of it. You can ignore most of what was going on before, say, the 1920s.
That's right, Adam. We dug up some archival healthcare radio stories. Here's a bit.
You know that unless some relief comes to you, that you're going to be in the undertaker's parlor on the old cold slab being embalmed for a funeral. Well, why do you hold back? Why do you...
The audio quality isn't great, so let me explain. This is Dr. John Brinkley, and he was huge in the U.S. in the 1920s, dispensing on-air health advice through his radio shows. Whatever problem folks had, he had one fabulous solution: transplant a goat gland into your body. It was perfect for everything from dementia to impotence to flatulence.
And if somehow a goat gland didn't cure your ills, you could always use Bonor's electromagnetic bathing fluid, Clark Stanley's snake oil liniment.
Oh, and my personal favorite, mugwump, for the cure and prevention of all venereal disease.
We're having fun here, of course, but
the point is that up until, say, 1910, 1920, most medical care in the U.S. was basically medieval, a bunch of potions that did nothing.
Luckily, they were cheap potions. Healthcare was a trivial part of the average person's annual budget. In 1900, the average American spent $5 a year on healthcare. That was cheap even then, $100 in today's dollars.
So it was a trade-off. On the one hand, healthcare was cheap. That's a big plus over the system we have today. On the other hand, it didn't actually make you any better.
Right. And of course, nobody had health insurance. Why would you get health insurance for something that doesn't work and only costs $5 a year?
So the first step in getting us to our current healthcare system, medicine got better. Doctors started curing the sick.
There were new and for the first time effective medicines starting in the 1910s and 20s, especially antibiotics. There was also a medical school revolution.
All this transformed healthcare, which was especially clear in hospitals. Before, say, 1911, hospitals were not anything like what we think of today. They were really poorhouses where the indigent went to die.
Melissa Thomason is an economic historian at Miami University in Ohio.
Hospitals have a radical transformation in the early part of the 20th century. Hospitals are actually marketing themselves as places to have babies, do appendectomies, take your tonsils out. They're focusing on generally things with happy outcomes.
Turns out effective healthcare is a lot more expensive than quack elixirs. All these clean hospitals, educated doctors, real pharmacological research, it costs money.
People were willing to pay when they were really sick, but it wasn't yet common to just go to the doctor for checkups or for a survivable illness.
By the late 1920s, hospitals noticed most of their beds were going empty every night. They wanted to get people who weren't deathly ill to start coming in.
An official at Baylor University Hospital in Dallas, Texas, noticed that Americans, on average, were spending more on cosmetics than on medical care. He said, "We spend $1 or so at a time for cosmetics and do not notice the high cost. The ribbon counter clerk can pay 50 cents, 75 cents, or $1 a month, yet it would take about 20 years to set aside a large hospital bill."
So Baylor Hospital wanted to figure out how to get ribbon counter clerks and anyone else they could find in Dallas to pay for health care like they pay for lipstick, a tiny bit every month.
Baylor started small. They offered a deal to a group of public school teachers in Dallas. They told them, "You pay us 50 cents a month and we'll cover your hospital visits."
And then the Depression hit. Almost every hospital in the country saw their patient load disappear, so the Baylor idea became hugely popular and eventually got a name, Blue Cross. Again, Melissa Thomason.
When I actually started studying this stuff, I got interested in it because I wondered why we have an employment-based health insurance plan. It doesn't seem very logical, but it comes right out of Blue Cross selling insurance to groups of people who probably wouldn't need it, that is, people who were healthy enough to work. The genius in marketing this by Blue Cross is marketing it to groups of workers.
Blue Cross eventually shows up in almost every state, but it's still pretty small. Not that many people have it. To get to our modern insurance system, you need another step. Go to war.
War has always had two fronts. The fighting front with its fury of battle, and behind the lines, the civilian front with its job of living and producing.
The war economy is an entirely different ballgame.
Economic historian Melissa Thomason says that if the Great Depression inadvertently inspired employer-based health insurance, World War II accidentally spread the idea everywhere.
Essentially, we go from being a mixed economy with mostly market and some government intervention to being a planned economy. I mean, think of government rationing on all levels.
Good afternoon. Here's a reminder from the Office of Price Administration. All old-type B and C gas coupons expire midnight August 31st. That's Tuesday night.
What they tell people is you legally cannot raise prices, you can't raise wages. And so you can't find workers who can work for you. You can't lure them by increasing wages. So what's a poor employer to do? They turn to fringe benefits. And they just started offering more and more generous health insurance plans.
Then another big change, the one that really cemented the system and got us where we are today. It came entirely by accident in 1943.
The Internal Revenue Service ruled that employer-based health care should be tax-free. Then, in 1954, a new law made the tax advantage of employer-based health care even more attractive.
And if you don't think a tax law change can have a huge impact on health care, Melissa Thomason has some data for you, pal. Just look at how the number of people with employer-based health insurance changed over time.
You start from 9% of the population in 1940 to 63% of the population in 1953. Wow. I mean, everybody starts getting in on it. It just grows like gangbusters. And by the 1960s, roughly 70% of the population is covered by some kind of private, what the AMA would say, voluntary health insurance plan.
By the mid-1960s, Thomason says, Americans started to see our system, where people with good jobs get health care through work, and people without good jobs have to look to the government, as if it were the natural order of things.
To Thomason and other economic historians, though, there's nothing natural or inevitable about it. It's simply the result of a series of historical accidents. I'm Alex Bloomberg.
And I'm Adam Davidson, NPR News.
Let me turn this off real quick. Where'd it go?
And now, more from NPR. Live from NPR News.
Let me reshare this to make sure you guys have it. Oh, I think this is it's probably gonna make me go back through everything. Okay, sorry guys. Don't look for a minute. Okay. Also, I forgot where I was. Okay. So universal health care, like you just learned, was almost a part of our original Social Security Act of 1935. However, FDR, in a compromise with Congress, dropped it out of universal health care out of the Social Security bill before signing it on August 14th, 1935. So the 1940s come rolling around. This is when we enter World War II also. So it was a critical point in U.S. public health history as well. Other countries are enacting universal health care at this time. Harry Truman appealed for a health care plan, but the AMA just refused. They completely opposed it. They started to charge their doctors a $25 fee to all doctors to fight the national health insurance plan. And that doesn't sound like much, but we're talking about the 1940s and lots of doctors. So if everyone's like throwing in $25, that's a lot of money going in just to fight universal health insurance. So this was the most expensive lobbying campaign up to that point. It linked national health insurance with communism. And this, of course, is right around when we're going into the war. Russia had, just at the turn of this century, just 40 years earlier, switched to, was turned into the Soviet Union and was under a communist rule. China was under communist rule. And the fear was there, and of course there was, Cuba wasn't under communist rule yet, but we were seeing all these countries convert over to communism, and they did not want that. So this is where they start to calling it socialized medicine. And this is where we really started to get into this debate over this socialism and communism are bad things, which communism isn't great, but some socialism can be good. Eisenhower took office and the healthcare bill died. And this is Truman. We should resolve now that the health of the nation is of national concern, that financial barriers are in the way of attaining a health should be removed, and that health for all of its citizens deserve the help of all the nation. And so really at this point, we were and still the only country without some sort of universal health care. So why didn't they pass it prior to this? basically the labor movement was not strong enough to threaten the government. There was just nothing there. AMA was self-interest, did not want it. And this is, there's a lot of money going into it. And then of course there's institutional reasons. Here in the United States, our hospitals are private. That's not that way in Europe. So it was a little bit easier. Also, all of Europe and had been pretty much destroyed in the war. So it was easier for them just to start up a new system as well. So we had less history with voluntary health insurance. Insurance companies feared income losses for disability and death benefits. Labor movements opposed it because this was a way to get people into the union, was to offer these great benefit packages, and all wanted to give members to get all wanted to give benefits to members. And then of course there's ideological differences. The US has more of a market mentality. We're known to be individualistic, self-determined, and of course distrustful of government, as all of these you just saw unfold. So there's always resistance to government programs, except during the Great Depression. So who knows what we'll see after this pandemic. Social Security was passed, but of course it was not healthcare. We also are a country that's tax adverse. So support for increasing access, but there's always problems with financing. So everybody wants more, but they don't want to pay for it. Americans support health reform and increase access. Americans don't support having to pay for health reforms and increase access. And they're afraid of reducing access to care or quality of care. But again, they don't want to pay for it. So this is that rise of employer-based health insurance that you just heard about. So private health insurance was funded by employers' partial contributions. And in some cases, early on, employers paid all the health insurance for the family as well. Not so much anymore. Now they barely cover the employee, and usually we have to pay in a little bit. In 1942, wage and price controls were put in place to reduce inflation. So when those wage and price controls were put in, then it was a way, at the same time, we were having to create, our manufacturing was going through the roof. We were complaining bombs and all the supplies for the war effort. So they really needed to get people to work, but they couldn't increase wages to get the better people. So that's when, as they were talking about before, that's when they used benefits to bring the better employees in. Post-World War II, in our economy, there's still a scarce supply of workers. Of course, we lost quite a few people in the war. We also were supplying, all commodities to Europe because they had no industry anymore. So everything was destroyed in Europe. We were the ones that were tasked to rebuild Europe. And so we had a lot of work and needed a lot of employees. But employers still wanted to attract the most competitive and talented employees. Healthcare became that thing to attract people to work. Demand for hospital care grew rapidly. In 1954, Congress amended the IRS code to allow for favorable tax treatment of employer-based health insurance. So that meant that you did not get taxed, and the employers didn't get taxed on the money going into your health care. Government offered tax breaks for employers providing health insurance, especially big companies. That really helped with big companies. Government became a main, so that's how the employer became the main system for getting health care coverage. Prior to the 1950s, health insurance only covered 10% of healthcare costs. During the 1950s, demand for hospital care grew rapidly. By the end of 1950s, the majority of working adults had private health insurance. The result, private-based health insurance funded we ended up with a private-based system funded by employers' partial contributions. Health insurance is seen as a benefit of employment. And at this point, unemployment was crazy though. It was at 2 to 4%, and most people were covered by health insurance. But who's left out? Of course, the elderly and the poor. So they did not have health insurance. And we already saw that. So just to reiterate, so by this time, the majority of working adults gained private health insurance. Employer-based health insurance became the primary way to obtain health coverage. Work-based risk pools. So, the way health insurance is paid is through these risk pools. And so what they take, why the university health insurance is so inexpensive, is our risk pool isn't very risky, right? So we don't actually pay that much for our insurance in compared to other risk pools. So my husband works for a construction company, and his insurance, his portion of his insurance and what they charge his company is 4 times more than what we're charged by the university. So our insurance is covered through me. But it's very interesting. They can still do this even with the ACA. And of course, this becomes a social norm. This is what we're used to. Health insurance is seen as a benefit of employment. So 1960s, Medicare comes into play. Only half of the elderly are covered by health insurance, and this is a huge issue. And so poor and workers without insurance are not able to cover our medical costs. Hospitals provide care to the poor and elderly, but charge private payers. So basically, what this really starts, it's called cost shifting. So when the poor and the elderly would come in, instead of charging them the full rate, what they were doing, and still do to some extent, is they charge more on the other end to somebody who has insurance. So those people who have insurance end up paying more. Medical establishment wanted the government to pay these, but could not dictate the care, but did not want them to dictate the care. So that was going to be a non-starter. The result was Medicare and Medicaid. So Medicare Part A provided hospital and nursing home coverage through the Social Security. And this is just short stay nursing home coverage. It's not like if your elderly person has to go to a nursing home for dementia and has to be there for the rest of their life, it is not covered by Medicare. Part D covers physician's bills, but it's not means tested. Everyone receives this. Medicaid is administered by the states, and this is the coverage for the poor, and this is means tested. So the result is that there's an increase in access to healthcare. And by means tested, let me go back. So means tested means that you can make as much money or as little money as you want, you still get the coverage. So for Medicare, because you've already paid into it, it's not means tested. Everyone gets Medicare, no matter what. Medicaid, you only get it if you're low income. So as a result, there was an increased access to healthcare. Government had a greater regulatory role, and healthcare costs increased because more people were going. So I'm going to go back 1 second because this is something I'm dealing with, and I think it's something that people don't quite understand. So as a senior, if you're a low income senior, you can be covered by both Medicaid and Medicare. So Medicare is their primary, and Medicaid becomes the secondary insurance. So my mother is covered by both. So it's pretty nice. That's why they're keeping her in the hospital, because she's got all the insurance. So right now, they're just taking Medicare because she's not going to be in the hospital for very long. Now, if she had broken her hip or needed to be moved, if she were injured herself worse and needed to be moved to like a nursing home type facility, then Medicaid would jump in for her and help with those costs. But if you are not low income, you are not covered for long-term nursing home care. You have to get that separately or pay out of pocket. Okay. So themes of the 1970s. So we increase access to healthcare, private health insurance, Medicare and Medicaid. There were few restrictions on physicians. Patients could see whoever they wanted at this point. Doctors could charge whatever they wanted at this point. The results were an increase of healthcare costs because there was nothing stopping doctors from charging whatever they wanted to Medicare, Medicaid, or the insurance company. And there were still a lot of problems with the middle class getting access to healthcare. So this really starts the medical arms race. So competition among hospitals led them to compete for patients on the basis of technology. So as an example, here in Santa Barbara, there's 5 hospitals. There's a lot of seniors here. There's a lot of money here. So this area supports those hospitals. So 3 of these hospitals can perform open heart surgery. The problem, Medicare and Medicaid paid the price, are paying the brunt of the medical arms race. So healthcare costs are rising rapidly. Access decreases. Lengthy recession means lower healthcare coverage and no assurance that the middle class has healthcare again. So, this is about when Nixon's coming in and he's seeing this problem. He's actually really good friends with I can't think of his name. He started, the man who started Kaiser Permanente. So Kaiser Permanente started as, hold on, let me see if I have a slide on that. I do not. So Kaiser Permanente was actually they were a construction company in the docks in Oakland. And in order to keep their employees healthy and working, they actually found that if they brought in their own doctors and started their own hospitals that that covered their employees and their families, it was very cost effective for them, rather than having their employees get other insurance. So basically they had company doctors. Many other industries did this. They did it in the timber industry, and I think in coal they have that as well. You would go to the company doctor. But this became they actually worked on, Kaiser was always more into prevention, and because of their history working for an employer. So Nixon was really close friends with the man who started this, and he really liked their focus on prevention and thought that that was a smart thing to do for the nation as a whole, like really work on prevention, have some sort of HMO type plan. And this is where this begins to rise. So all the employed people so Nixon's plan was all employed people would be covered through a combination state and federal subsidies to employers. The poor and unemployed were covered through subsidies. He really encouraged this HMO, this Kaiser plan, and it banned exclusions for pre-existing conditions, and did not and allowed limits on spending for each one insured. So Edward Kennedy killed this. Why? So Edward Kennedy, even though he's pro universal health care, he killed this because he did not feel it was true universal health care, because you're still going through the employers. He really wanted a government run system, more like a European system. And so he later then had said it was probably the biggest mistake of his career. Of course, not counting Chappaquiddick, which is, you guys could look that up if you don't know about it already. So then Oregon gets into the medical field. So the goal was, they really wanted to increase coverage of healthcare, right? But they're going to go about this by limiting what they covered. So as usual in Medicaid, there's not a lot of money. And so you have to do something. You either have to ration healthcare or limit the number of people that are allowed. So they decided, instead of limiting the number of people, they wanted to cover everybody, but they were just going to limit what was covered. So they decided they were going to get, because only Oregon would do this, they decided that they were going to ask the public what they thought they should cover. And they also got medical opinions, polls, surveys went out on what essential healthcare meant for people. The problem is no one knows what essential healthcare is. Like, even doctors will disagree on what essential healthcare is. One will say, the plastic surgeon is going to say whatever they do is essential. Cardiologist, of course, I was going to say something else. And of course, there's also always going to be some sort of controversy over rationing of healthcare. It's really hard to ration healthcare. So what ended up happening is, so they decided they were only going to allow basically comfort care for certain types of cancer diagnoses. And so I believe it was an elderly woman was diagnosed with cancer, and there was a new treatment that came out, and Oregon wouldn't pay for it. And so, and she didn't have other insurance. So that ended up going to court and fighting them. I think in the, of course, she passed away while this is all going on. So Oregon decided they're not going to cover cancer for treatments of patients with less than a 5% chance of survival over 5 years. And you can't really draw that line. It became a huge problem. And so what ended up happening in the end is it went to court, and Oregon no longer has this plan. But we have a lot of really good data from it. As well as, I don't know if I bring it up again. So Oregon is very good about giving us good stuff. And then a couple of years ago, Oregon decided that they can't ration. They've already learned that. So instead, they're going to restrict the number of people going into their health system because they ran out of money. And I think I have this on here somewhere. Anyway, so they decide to restrict and have a lottery. So you have to make that you have to be low income, plus you go into a lottery. But all of your medical is covered when you're in the lottery. And they that lasted maybe a year and a half as well. But now we have really good data on what it is if you are in like how having insurance affects the overall health of a person, and we're still following those people. Oregon's good for research. So these are some reference books if you want to go back and learn more about some of the topics that we've covered so far. Of course, you have the great influenza, and we are working our way through that one. Okay, let me see. Okay, so we're going to delve a little bit deeper into insurance, but I'm going to stop this video here, and I will start again. I'm going to sort these because I know this one went on for a bit. So I'm going to end here, and for those of you who are continuing on today, we're going to pick it up with insurance. And I will see you all in a bit.